Good afternoon, everyone. Welcome to the inaugural Ethics for Lunch. I'm glad we have such a great turnout for this session. Just to let you know who I am, I'm speaking also on behalf of Cinda Rushton, the co-chair of the Ethics Committee. My name is Mark Hughes, co-chair, also a faculty member in Internal Medicine, Palliative Care, and the Berman Institute of Bioethics. Ethics for Lunch is co-sponsored by both the Ethics Committee here at the hospital as well as the Berman Institute of Bioethics. Wanted to just give you a little bit of background about the Ethics Committee and then talk more specifically about why we've instituted the Ethics for Lunch. So the Ethics Committee, as a hospital committee, serves our community. We do that in three different ways. First of all is through ethics consultation. So you're going to hear about our consultation process today. This is something available to patients, families, health professionals, anyone in the community that is involved in patient care and has concerns about a particular case. We can be called upon to help facilitate a discussion about that case, try to figure out what's ethically permissible, try to help reach resolution when there may be conflicts involved. The other two things that we do are education, which is our responsibility to the community to make sure people are aware of the issues, both societally as well as institutionally. So this is one forum we do this. We also do it through our consultation process. We sponsor lectures. There are various ways that we try to educate people about the ethical issues. And then lastly, we deal with organizational policies. We sponsor or co-sponsor a number of hospital policies that bear on ethical issues. With Cinda, I participate in the administrative committee for the hospital. So there we speak to larger organizational issues and really try to have a voice to think about the moral underpinnings of what we're doing in healthcare. The lights are probably motion. Somebody move when they. So we have about 40 members of the Ethics Committee, and for our consultations in particular, we use a team process. We definitely strive to be interdisciplinary, so we have representation from all the health professionals, as well as lay members from our community, and they will have core teams that will be called upon to handle consultations. We do this 24 hours a day, 7 days a week, so we're always available by pager. You have information on your handouts about how to accomplish that, but we welcome consultations. It doesn't just have to be for really challenging, like can't come to an answer as to what to do, but if you need that kind of conversation, we can be called upon for that on an ad hoc basis, as the case may be. The larger Berman Institute also has about 40 members, faculty members that serve a variety of disciplines, not just clinical ethics, but research ethics, public health ethics, philosophy, trying to answer both scholarship questions, research questions, and then also inform things like clinical ethics like we do here. I wanted to tell you about Ethics for Lunch. So this is our inaugural. It's going to be monthly, the third Tuesday of every month. So great participation today. We'd invite you to come on a monthly basis and be part of that conversation. The logistics for Ethics for Lunch, it's helpful for you to swipe in. That gets us to know who's coming and how our attendance is doing, but also for you all, if you want to get like CME credits or CEU credits, logging in through the badge system accomplishes that. You can also sign in if you are don't have a badge, not a hospital staff member or university member. You can sign in. We can get you information, have our mailing list sent to you, and so on. So that's Ethics for Lunch. Again, this is supposed to be a combination of members of the Ethics Committee or the Berman Institute having a conversation about key topics. And they can be the very complex, challenging cases like today's topic is, or everyday ethics we also want to handle. But then engaging with you all, get your input about some of these key topic areas. Let me have the panel introduce themselves. So we have Ty, Helen, and May. Ty, how do you start first?
Good afternoon, everybody.
Good afternoon. Gotcha.
Good afternoon. 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 Good afternoon Well, thank you for having me. My name is Ty Crow. I am a member of the Ethics Committee, and I have a day job, which is the Department Director for Spiritual Care and Chaplaincy. For those of you who are somewhat familiar with our department, we are, like many other departments at Hopkins, a blend of students and permanent staff members. We have a core of chaplains who work in pediatrics, oncology, and then with family advocacy. We blend that with part-time chaplain students and full-time chaplain residents. And one thing I did want to mention that many people don't always remember is that we are on call 24/7.
My name is Helen Michaelisco. I'm one of the senior social workers in the Med-Surg unit here at the hospital. There are 5 departments of social work, and there are 5 positions for social work on the Ethics Committee. We're down a few spots, unfortunately. I think social work brings to the process several things. We have been trained to look at individuals in terms of their functioning within systems, their family, and their community, and various other systems that will have an impact on how people behave, how they feel, what their experience has been. I think we also bring to the table a comfort level. Although social work is part of the team, we don't give needles or threaten in any way bodily physical harm. So you'll find sometimes that families are much more comfortable speaking with us about issues that they may not be so comfortable bringing to the physicians or the nurses. We have the time to sit down with people, hopefully, to be able to do that. Thank you for being here today. I think we can answer some questions for you. And I think you make is very impressive, by the way.
As was already said, I'm Meg Garrett. I'm Senior Counsel and Practice Group Leader for Risk Management, Regulatory, Ethics, Patient Care, and anything else you want here in the legal department. There are about 30 of us lawyers. Only about a small percentage are on this campus, and only a small percentage do you generally deal with on a day-to-day basis. We are available 24/7. We try not to tell, no, excuse me. We are available live here 24/7. And I have 6 wonderful people who love to be called in the middle of the night. And if they need some backup, it's me. But essentially, we are available to you. We certainly are available to the Ethics Committee. I've been a member for at least 25 years. And I certainly, it's a very important part of my position here at Hopkins. In fact, probably one of the most exciting things that I've had an opportunity to do, and also the most emotionally draining that I had an opportunity to do. But anyhow, thank you for joining us today. This is probably one of the hottest topics we get called on, and probably one of the not so easy to answer topics.
So before I just go over the case, which you do have on your handout, I also want to acknowledge Dan Finkelstein and all his support for Ethics for Lunch. He was really instrumental in getting this up and rolling, and we appreciate Dan's support throughout this process and everyone involved in making this happen. Okay, I will speak into the microphone. I'm not on American Idol, so I don't know these things. All right, so this is a case that is really just presented in the abstract. And one of the key points I'm going to make when the Ethics Committee is called for a consult of a case similar to this is we need to know the details. Context matters in how to resolve these tough ethical dilemmas. So I'll just give you the brief overview of the case. This is a critically ill patient. We know nothing about whether they're an adult or a child, nothing about the particular circumstances of that patient, but they are critically ill. They've been sick for some time in the ICU, so a month in the ICU. They've been in shock, so they have low blood pressure, requiring medication to support their blood pressure. They've had respiratory failure, so they need mechanical ventilation to help with their breathing. I haven't told you anything about how they got into this dire circumstance, whether it was a surgical procedure, medical condition, or the like. That's also going to matter in how we figure out what to do for this particular person. When this patient was able to make decisions, right now they are let's say, unconscious or minimally responsive and really not able to participate in decision-making. But when they had the capacity to make their own decisions, they said they want to work towards a cure. Whatever the treatment is, whatever their acute condition is, they want a treatment to bring them back to their healthy, functioning life. So in essence, the way that gets painted is do everything. Do everything to get me better. Now that the person is unconscious, family, surrogate decision makers are involved in the process to help in making these ongoing decisions in the ICU. In this circumstance, the family is consistent with what the patient has said of, we want to work towards getting our loved one better, do everything. We now have an instance where it's pretty clear this person is so critically ill that some measures that we would institute would not be effective. It's the consensus of all the clinicians involved that something like cardiopulmonary resuscitation would not work or have a very low chance of being effective. In this circumstance, you could say that if the heart stops and the breathing stops and all the resuscitation members that we would institute, if they brought the heart back, might only work temporarily, be a low percentage of chance that it could bring the heart back. In all likelihood, the person would never leave the hospital. Based on the medical literature that we have, that's often the circumstance where people are critically ill, such as this patient. We've had family meetings, the clinicians involved have had family meetings, and they have been firm in this idea of continue to do everything to support the person to get them better, and that would include cardiopulmonary resuscitation if there is a cardiac arrest. The team, now with consensus that this would not be effective, is wondering, can we institute a do not attempt resuscitation order, a DNR order? So they've invited the ethics committee, the consultants, to help with conversations with the family in this case. So just with that bare bones facts of the case, I'm going to turn to our panel and say, okay, you're either the ethics team leader or you're a member of the ethics team. How would you start thinking about this case? I'll have you start.
Well, certainly one of the first things that comes to mind is what is this family really hopeful for? And of course, I'm a member of the ethics team, and it's hard for me to take my chaplain hat off, of course, so I'm coming at it with, I wonder what their spirituality is. I wonder how that's influencing their viewpoint, and I also have in mind how many of our patients here, especially on this campus, are self-reporting as spiritual or religious. I think that number is north of 70%, and I think that there's a part of that 70% that would identify as very spiritual or very religious, meaning that everything that they see or do or decide upon, stressful or not, is coming through the lens of their faith. And so with that, I think that plays a part in, potentially, we don't know exactly what this family is, but that would be one of the questions right off the bat. Then certainly about family disagreement. I mean, I think in terms of social work and chaplaincy, we're thinking about family dynamics. We're concerned about support of this family, who's supporting them, who's not, who's visiting. And then, what is their hope? And I think that's also tied often to their spirituality. What is their hope? And what other feelings and how are those being addressed in the care? Not everyone has the opportunity to pause and address every feeling, but it is assumed that there's a lot of grief, a lot of anticipatory grief. There's loss that's already happened. And the vision of what will come is on everyone's radar, except no one might be talking about it. So these are the things that I think that the team would be wrestling with. The other thing that stands out about in the write-up for me, and I'll pass it on, is the clinical team wonders if it's in the patient's best interest. And I think that's a pretty soft way to put it, because I think typically there can be a lot of stress, especially if your own personal values are that, oh my gosh, if this were my father, or if this were my mother, I wouldn't be putting this patient through this, or I can't believe this family is taking so long to come to the conclusion that we all have arrived at. And I think that can really cause a lot of distress amongst care providers. So that there's some aspect of care for the team, and how is the team doing?
So from my standpoint, there's several things I'd like to know. Number one, what is the ethnicity or culture of this individual? I think most of you have probably had the opportunity to work with the multicultural population that we have here, and they bring with them, from wherever, all their experience with medicine, their family beliefs about medicine, who should be the spokesperson, who should make the decisions. So you really do want to look at that and pull in an international office if you can to help us understand that a little bit better. Again, I think you're going to see there's some overlap between us. What's the relationship with the family? Is there cohesiveness? Is there fighting? Are they all in agreement, or is there a divide about what kind of treatment dad they want? I'm assuming it's dad anyway. We'll say it's dad. Did this patient ever mention to the family their feelings about being on a ventilator for any length of time? People will often say, I want everything done, not understanding that having everything done may mean terribly invasive procedures in an ICU for months at a time. That is causing distress to the family watching it, and is also causing distress to the staff to have to perform these type of processes. Who's the strongest member of the family? Because they're really going to be the person who can be able to flow and help the family understand. What's the relationship with the team? Everybody's had experience where there's a family who is fairly adversarial with you, who's angry, who's blaming. They have to blame somebody for the illness or the outcome, and you guys may be the primary focus. Most importantly, I think we discuss this a great deal in our ethics committees. What are the goals of care that this family has for this patient? And what are their expectations? Do they truly believe that this individual is going to get out of the ICU and resume their normal functioning and be the way they were before they came into the hospital?
So I get the call at 3 in the morning saying, will you come to an ethics committee at 7? But usually Mark or Cinda give me a little more information. And by the way, Cinda Rushton, the co-chair also of our committee, has texted me her plane has landed and she will be here as soon as possible. So the first thing I do at 3 o'clock in the morning, because they usually bypass my attorneys on call, is I pick up the Hopkins policy MEL004, which is futile or medical ineffective treatment. I know most of you have this memorized, but for those who forget a few points of it, I'm going to go over a little bit of it. I also, it's where I'm very schizophrenic in my life. Meds don't really help. I don't know where one of our people, Michael Clark, is. He's on our committee, our psychiatrist. But it's sometimes challenging being the lawyer on the group, also involved in ethics, because I've had a fair amount of training in ethics, and I'm also a nurse. So it's very challenging to try to put all the pieces together. But generally, when it comes to medically effective treatment, we really need to look at it from a legal standpoint. And I'll tell you the punchline at the very end. So what we have done, the lawyers and the ethicists, we really do work together. And there are such things as ethical lawyers, no matter what some of you think. But what we did was we put together a document that would protect our providers from a legal standpoint and also give them guidance on how they should handle these kind of situations. So basically, this decision to withdraw should be based on goals of care. And our policy outlines the legal aspects of medical ineffective treatment. Basically, under most circumstances, our patients have the right to make their own decisions, good or bad. I want to be on a ventilator forever, I want to be off, in 3 seconds because my wife won't care about me, or whatever it might be. If the patient is incapable of making their own decisions, then we look to their healthcare agent or their surrogate, depending on the circumstances. If a surrogate or a healthcare agent determines that they want to withdraw life-sustaining treatment, basically the providers have to document that the patient is terminal, permanent vegetative state or end-stage condition, which I'm not going to go into now because I know we're going to have a lecture on advanced directives. The Maryland law basically says that a physician is not required to render treatment that they consider to be medically ineffective. Well, another member of our ethics committee is an individual, an attorney by the name of Jack Schwartz. Many years ago, Jack helped write this law, and it's really great now having him on the ethics committee to try to interpret this law. Because to be honest with you, there's no national consensus on what's medically ineffective. It's probably, there aren't a whole lot of cases on it, though I had one of my new University of Maryland law clerks review this yesterday, actually came in on a holiday, and it's not a whole lot of cases out there on this particular issue. But this policy is used when the family really disagrees with the decision as to whether or not to resuscitate when a physician feels it's medically ineffective. So what is the word medical ineffective? To a reasonable degree of medical certainty, a medical procedure will not prevent or reduce the deterioration of the patient, the health of an individual, or prevent the impending death of an individual. So we look at this case, and we're going to have a lot of time to talk about this afterwards. What does the physician have to do in this situation? They have to inform the patient and the family of their opinion that the do not resuscitate will not fit with the goals of care, and certainly is not going to enhance a prolonged life. They have to explain the medical condition to the family in language that they might understand, and talk to them about options, hospice or whatever other kind of things, and also give them the option of transfer. Well, it's kind of tough because 99% of the time when we at Hopkins say something's medically ineffective, futile, there's not too many other places that are willing to take them. So that becomes a challenge, and we'll talk about that along the way. The policy also requires that the provider and the team get an ethics consultation. This is where we come in and start reviewing the case. And it also says that there has to be a legal consultation. The physicians then would document the certificate of the condition, meaning it's medically ineffective. 2 physicians need to do that under most circumstances. And they need to withdraw with dignity. While there's this discussion with the family, the attending physician must be involved in the process the entire way. And the goal with the ethics committee is that we meet with the staff, the patients, the families, and try to come up, usually we try to make sure to have the family and the providers have a mutually acceptable plan of care. But in the sense that they don't, then we try to help with whatever we can do to ameliorate the situation. And the bottom line is, in very rare circumstances, very rare, we have situations where we can't come to an understanding. And the law truly allows our provider to withdraw or withhold unilaterally. And the law also says that the provider is immune from liability for unprofessional conduct, criminal prosecution, and cases involving lack of consent or authorization. It's really critical that our providers follow the policy, again, to make sure that we've dotted every I and crossed every T. These are not the kind of situations that we like to have. We certainly always want to have agreement amongst the surrogates, the healthcare team, as to what the goals of care are for the patient.
Great, thank you all. So what we'll do, I want to just ask a couple of questions of the panel, and then we'll turn it out to you and see if you have questions or comments about this question. So what I heard common in all 3 was this idea of goals. You have to meet, ideally if the patient is able to communicate, you would speak with them, if not with the family, and really trying to get an understanding of what are their goals of care. So as an ethics consultant being called upon for this kind of case, what would you want to hear from the family? You've said things like, well, there might be grief or anticipatory grief. There's hope, obviously, for the person getting better. How would you try to get at the goals of care and trying to see if there are commonalities or shared goals or shared values that the family has with the healthcare team? Any 3 of you?
It's very helpful when the team comes to the consult to meet with the family separately. I think almost universally they feel that they have someone who's willing to listen, who is not vested one way or the other about what should happen to this patient. But many times, patients or the families really don't understand the medical implications of what's going on with the patient. We'll find that. So you start out by asking, what is the ultimate that you're hoping for? What do you see as the end result here? So that we can get some idea of where the team stands versus the family and try to bring that education together so that there's some common understanding. That doesn't always work, unfortunately, but that's, I think, one of our biggest aims, to help the family really understand what futility means.
I think so often the medical team gets entangled in, we think this is futile and they keep talking to the family, we think this is futile, and someone talking to the family without actually listening to the family. And so often coming in as an ethics team, and like Helen said, listening to the healthcare team and then meeting with the family, it's amazing how close they really are at times with what the real alignment with the provider. But they say, every time we walk in the door, they want to withdraw, they want to withhold, they want to do this. And I think that's one of the lessons that we've tried to teach folks from the ethics standpoint is, give patients and families a chance. We have calls a fair number of times looking at the futility. And I would say probably half of the time, or I don't know percentage-wise, but it's substantial that the ethics committee doesn't feel that we're really at the medical ineffective or futility. And I think sometimes people get frustrated and want to throw up their hands and so on. But clearly, patients and the families have a right to make their own decisions. And it's in those rarer circumstances that we really do see futility.
I think the thing I can add here is that sometimes families get confused when different services are saying different things. And even if it is said once and it was 8 days ago, that one family member remembers that and has now hanging on to that, whatever that was offered. And so because we were offering such a menu oftentimes of things that we could do or what might happen, I think it can get overwhelming. And so when we're actually stopping and listening to the family tell their story, sometimes these things come out.
Can I segue? This is just a bit of an anecdote to segue on Meg being called in on a committee, as a committee one time on a baby who was transferred in from another hospital to the PICU with no real chance, I think, of survival. This baby was ultimately going to die, except for all the medical stuff they were doing. And when I met with the family, the father said very clearly to me several things. As soon as I walked in the door, I didn't know anyone, and they kept asking me how I wanted my baby to die. They never talked to me about what was going on. The thing that really touched my heart was, he said, why in the world would that other hospital have transferred him here if there is no hope? This is Johns Hopkins. I thought you guys would do everything. I didn't have an answer for that one.
And we often, as a tertiary or quaternary care center, we're often admitting patients who have that hope of this is the place of last resort, they can do anything, and when you're mentioning hope, that it has to happen here. There also may be instances, I think, where patients or families have been told this won't work, and lo and behold, they institute a treatment and it does work. And now they're influenced by that previous experience of, well, do I believe, do I trust that when they're saying that this is going to be ineffective or not going to work, is that actually the case? I think the third aspect of that is also the uncertainty. We deal with a lot of things that are in the gray zone of we don't know what's going to happen. We have a pretty good idea based on the medical literature. There are probabilities of certain conditions. A person has sepsis or multi-organ system failure or metastatic cancer, where we know that CPR based on the literature, does not work. For this particular person, especially when it's family hearing all this information about their loved one, is it going to work for them? And they're going to hold out that possibility that my loved one will be the one exception to what the literature says. I'm going to hold that out. The Hail Mary pass, I'm just going to go for it and hope that it works out. If it doesn't, so be it, but at least we've given it a shot. Any other aspects of the patient or family side? We're obviously striving for patient and family-centered care. Before I move on, I also want to talk about the healthcare team, but anything else that we should be thinking about from the family perspective in cases like this?
I said, I'm sure there is.
Okay.
Well, sometimes the family says, we're going to sue you. And that seems to be the immediate hands-off by the providers calling Meg and, whatever, and, what do I do now? Again, I think a lot of it has to do with communication with the patient, communication with the family. Having the ethics team involved certainly helps. But there are going to be families that are going to say, look at the situation with the family in California who had the 12 or 13-year-old child that California said was brain dead. And the family managed to transfer that child to, I believe it was New Jersey, and I'm not sure the status of the child now, but there were court cases and all of those kind of things. I mean, we really try very hard not to do the court case. I mean, at the end of life, families are going through enough without having to fight the hospitals and so on. So, knock on for Micah, in my 30 years here, we have not gone to court, and hopefully we don't have to do that.
I do want to talk about the healthcare team. So Ty, you had mentioned that obviously these are stressful situations. You're seeing a person who's very sick. You're trying to do the best by them. You're trying to determine what is in their best interest. It's stressful, but it can also be morally distressful. So you feel that there's a right course of action, a right thing to do, but you're being impeded by, on the basis of the family's wishes. How do we think about the moral distress and just the stress in general in this kind of intensive care unit taking care of these very sick patients?
Well, I would say the first step is to acknowledge it. Say it out loud to yourself. I mean, I think that these things aren't easy. It's not something we walk around raising our hand saying, I'm morally distressed. It's something that sometimes signals inside of us in some way. And to take care of yourself, to have the consultation, get support from your peers, I think it's very, very important. Especially for folks that are working on the front lines, caring day in and day out for a particular patient or situation. And your values are really conflicting with what the decision and the course of decisions are made. Now, hopefully, you've gotten in touch with that a little bit, because obviously there's going to be minor tensions throughout your career. But I think when the larger situations arise, to take note of what's happening inside of you and pay attention to that and be tender with yourself, and also to reach out for support. I think that's important. I think that's something we want to create more of a culture of here at Hopkins, where people feel more comfortable about reaching out for support, because these are not easy. I think that's another thing when the ethics team meets with the family. Typically we're meeting then with the team either before or after separately. And we hear a lot of stress in the voice tones. And I think it's important to, at minimally, to acknowledge it.
I think there's never been a case that I've worked on or seen in my 37 years of being here that I don't believe that the medical team has the best interest of the patient and family always. So Ty spoke a bit about disagreeing with what the family's wishes are, but there's also a point where you're going to find a staff member who agrees with the family against the decisions of or the wishes of the rest of the team. And there's a conflict there that doesn't get any better unless it's brought out and you're able to discuss that. But that can be pretty intimidating, I think, if it's with your attending, if it's someone you feel that has some power over you and your career. I'm particularly of concern about the nurses who are at the bedside in the ICU for long periods of time. They're the ones who are doing the painful procedures and really, frankly, struggling with that. So it's very important for the team to go together to discuss what's happening, and particularly for the bedside individuals to work with their managers, looking at what resources are available here through human resources to help groups like this manage the stresses of these very difficult patients.
I want to speak for the med students and the residents who also have similar moral distress and multifactorial, because sometimes for them speaking up to an attending may be what some of them have told me, academic suicide. And we've really worked hard on trying to improve that culture. I'm not sure that it's 100%. But after some of the consults, or even before, when they call us for either a legal consult or an ethics consult, the med student or the resident will say, well, my attending doesn't want me to call you, but I really feel I have to. And I think part of our role as the members of the ethics committee is try to make those folks feel comfortable, try to have the attending feel comfortable calling the ethics committee, and it's not this punitive committee. Some of the providers, some of the healthcare team will tell the family, well, the ethics committee's coming in and they're going to tell you what to do. As you all know, that's not our role. Our role is advisory. But, it's kind of like them saying, well, the lawyer's going to come in and tell you what to do. I think that, trying to set the climate to be more compassionate sometimes is part of the role of the committee when it comes to the healthcare team. But the moral distress, like you said, for the nurses taking care, actually I wish Cinda's Uber got here a little. Cinda's been doing a lot of research on moral distress, especially in nursing, and I think it's actually doing a chapter or a book or something like that. She's really the one that has studied it, but we've seen it. We haven't done the research on it, but we see it, and we've seen the tears. We've seen we try to go back afterwards and do kind of a debriefing on some of these consults because they really are so emotionally charged.
And trying to find opportunities to build moral resilience. So figuring out how people can cope with these challenging situations and know that it's a difficult path to go down, but hopefully build resilience for the next case and figure out how to deal with it perhaps a little differently in the future so that they don't have the burnout. Cinda's also written a fair amount about the burnout and when there's ongoing stress or distress, how to help people cope with that as clinicians.
And again, one of the challenges is if indeed, and again, very rare times does it happen, that there's a withdrawal of life-sustaining treatment over the objection of the family. It's very difficult for the care provider at the bedside to watch that the moral distress again of the family, but clearly causes a lot of angst for the team.
And to know that there are also institutional policies. If really a person does strongly object, we do have policies with regard to conscientious objection. So if you feel that you just cannot participate in this case, it violates your conscience or what you think is the right thing to do. There are mechanisms in the institution to have others provide that care. So there is a process for that. There are ways to handle that if it really is too challenging for you. We painted the case as one of consensus, that the team is in agreement across the board. That's often not the case. We may have clinicians that are still, as part of their responsibility to the patient, I'm going to see you through this critical illness and feel that they need to continue to push for that treatment, for that ultimately cure of the patient. So it's never clear-cut that everyone is on the same page on the healthcare team. And part of our job is to tease out exactly where do we stand, what are the common shared values that we might have as a team going forward. Can we have an approach that we present to the whole family in a united way, even if we might have disagreements, but still trying to serve the best interests of the patient. But one other thing I wanted to just point out with regard to moral distress, the way I and my colleagues often teach about ethics is conflicting moral obligations. So if you think about the tried and true, there's the 4 principles of medical ethics: beneficence, doing good, doing the best interest of the patient; non-maleficence, do no harm; respect for autonomy, trying to find out what the patient's wishes are, how they feel about things, and if not from them, from their family as a spokesperson for them. And then lastly, justice and contextual features with regard to a case. And part of the challenge for clinicians is trying to meet all of those obligations and recognizing that they can be in competition. So trying to work towards the patient's good clinical outcome, medical outcome, may be in conflict with constrained healthcare resources. And being a steward of those resources and trying to figure out how as a clinician and as an institution do we think about the resources that are being used for this particular patient relative to other patients. When we're thinking about the beneficence and trying to get them better, how do we weigh that against the non-maleficence of the harm and the suffering that might be involved in being on a ventilator, being in the ICU, the distress that it causes to the family, the harm that might have come to them, seeing their loved ones sick. So there are lots of competitions in terms of how we think about the principles and values, and you have to navigate through all those. It's not an easy solution.
I just want to make a comment. Just like the healthcare team is somewhat conflicted, believe me, the whole ethics committee doesn't always agree either. I mean, we really do have a lot of discussion because it's an interdisciplinary team. Everybody comes from a different, walk of life or academic background or whatever it might be. And our team truly believes that everybody should be heard, and they are. But it takes a while sometimes to get a consensus to determine what would be the ethical parameters around something. But I think that's the good part about the team is that nobody seems to be shy about speaking up about what it is that they feel is the ethically permissible or appropriate way.
So I'm now going to turn it over to you all, see if there are questions or comments, things about how you think about these cases. And utilize Peter to walk around and speak with Mike. I saw your hand up first.
Testing. Thank you so much for putting on this event. This is really fantastic. So what I'm curious about, among other things, is as you discussed, right, medically ineffective, futile, potentially inappropriate, these terms are constantly being debated and there are ambiguities with these terms, and on the one hand we want the terms to be a little bit loose in our policies, perhaps to allow for some discretion, but I'm curious to what extent you think that discretion ought to be in place on the part of the clinician. So if we have doctors saying, well, resuscitation would be non-beneficial, right? In the clinician's mind, this might be very clear-cut, right? A black and white sort of statement, right? But then you get at, well, what do you mean by benefit, and how are you weighing those potential benefits from your perspective against other benefits that might be relevant to the family or to the patient? And so, for example, if we focus on, well, the patient isn't going to return to baseline. Well, it might be that the reduced baseline is something that the patient would be or would have been comfortable having, even if it's a lower baseline than what a lot of us would want for ourselves. That doesn't mean from the get-go that it's not potentially a valuable quality of life from the person who's actually going to be experiencing it. And I spoke to a doctor who had a patient who was going to die probably within the next few months, but he was very non-compliant with medication and engaged in substance abuse. And on the basis of that, he invoked a unilateral DNR order. And from his standpoint, it's like, well, resuscitation ultimately isn't going to benefit this guy. It's not going to reverse his underlying medical conditions, and he's going to die anyway. It's like, well, that, again, this is one of those areas where, has he overstepped in terms of his clinical judgment? And if so, again, where's that line where you say, this treatment is equivalent of treating a virus with an antibiotic versus, well, from my standpoint, this is not a quality of life worth having, and I'm going to recuse myself as a physician or find another physician who agrees with me and invoke a unilateral DNR.
So I think that's great. Those are all great points. So the futility debate, if we call it that, has been around for 20, 30 years. And that distinction that you had at the end of the quantitative versus qualitative futility. So quantitative futility meaning it just will not work. You have a viral infection, you're giving an antibiotic, it's not treating the viral infection. A person is in rigor mortis, they've already died, performing CPR in that instance is futile, is not going to work, it's not going to restore the person to life. So there are those clear instances of where it just won't work. I think where there are laws in certain states, such as Maryland, they are trying to be consistent with that idea of medically ineffective and just will not work, especially with regard to the impending death of the individual or not able to prevent the deterioration in the condition of the patient. That's one. So qualitative futility, where there's a value judgment as to the quality of life, I think that is challenging and shouldn't just be the realm of the clinician. I think that's an instance where you do need to engage the patient, ideally, but if not them, then the family, about what does it mean to have this quality of life? What's the expected outcome with regard to their functionality, their quality, and is that a life worth living? Sometimes you can only answer that when you're in the moment, when you're experiencing that condition. And again, there's going to be, it's also tinged with the uncertainty of how things will play out. But the qualitative futility, at least in the old way of thinking about futility, really should be in the realm of the patient and family and that ongoing communication with them. Others want to comment about that?
Again, it's an anecdote, that's what I do best. There was a situation very much like this on one of the floors where the physician just wanted to stop treatment, withdrawal care for this gentleman who had an ongoing illness for 15 years, feeling that there was no chance for him to get better, and if he did miraculously get off the ventilator, that his quality of life would be very poor. When we were able to sit down with his family, we were able to ascertain that this individual for 15 years had said, this is what I want, this is how I'm going to live. And prior to his admission, this last admission, had been totally dependent at home with a caregiver, but that was all right for him. That he still felt joy in his life and was able to have some interaction with his family and feel that it was okay. But there was truly a conflict between the physician and the family over this. Ultimately, the patient got off the ventilator, went home, totally dependent, but that was his goal. And that may not be the lifestyle we would want for ourselves. But in talking with the family, I think the team was able to learn that this was okay for this guy.
I think the other point that I would mention in terms of that particular position you mentioned is that again becomes the role of the ethics consultants. You need an independent third party to really understand the facts of the case and not have these quote-unquote unilateral decisions where there may be value judgments at play. So it really is trying to respect the patient's voice, make sure it's heard, and as much as possible when it is a value judgment, that their voice gets recognized.
Thank you so much. This is really wonderful. I'm so glad you do this every month. Okay, I was wanting to pick up on consensus because you talked about there not being consensus in the medical team, but what about when there isn't consensus in the family? And even if the patient is supposedly competent, there are different pressures that different members of the family may place on that patient. And how successful do you feel the ethics committees have been in being able to mediate family disputes? They didn't just start, obviously, with someone that's in there. They come with a lot of history. And how might that be affected by religion? The really strong religious values are very close to me, and maybe they're not, it's not appropriate. So could you talk a little bit more about that? This problem has everybody in the family on the same side.
So I can't talk about religion. But I will talk about it.
Sure, Laura, you can talk about it.
No, I defer to Todd. But as far as consensus with the family, that is a challenge. And I can remember one consult where Mark Hughes and another male physician put me between two sisters who were fighting it out. Never forget that. But I mean, essentially, let's not talk about it in this particular scenario with unilateral per se, But in general, when we have such a conflict between family members, we try very hard as an ethics committee to get some common ground with the family. But again, there are 2 or 3 kids, 4 kids, whatever, surrogates can't agree. At the end of the day, we end up having to go get guardianship. Not, not that often, but it absolutely does happen. And at some points, the judge just makes the decision that it's none of the 4 kids, because no one's acting in mom's best interest, or dad's, and so on. That's what we've had to do, and we really do try, but sometimes it just doesn't work.
But could I just follow up? When you have unilaterals like this, do you find that the clinicians will realize they've got some family member on their side and try to work with them to try to convince the rest of the family? So have you seen any of that?
Certainly.
dynamic? Okay.
Certainly.
I'll just introduce Cinda. Cinda, you can say hello, and I don't know if you want to field any of the questions here on out.
Happy to, whatever comes my way.
Ty, do you want to speak at all to, so if there are strong religious beliefs that might be influencing how the family thinks about it?
Yeah, those are really bad. I think it does present a sensitive topic because we typically are going to win the argument with God. And if someone really feels like they need to hang on to the idea of a miracle happening, I guess is where this is going. We could have a whole ethics for lunch on miracles. But in this, just to be brief, I think it's important that a chaplain is involved. And I think that the issues around spirituality and faith obviously are major players here in stressful events and making decisions. And so as people feel like they really need to hang on to their faith, oftentimes it's more of a transition about how their faith is going to help them cope through this. And how do we get at that? And who's primed to have that kind of conversation? If that conversation isn't happening, or if the family has refused, I think that does present more of a challenge. But typically, a skilled chaplain can come in and engage that family and hopefully build some rapport and some basic trust. Oftentimes, chaplains are seen as neutral players, even though we all have badges. But there isn't an easy solution here. Sometimes it's time. Sometimes it's time related to a distant family member that's coming in and flying in from another state that says, wait a minute. And of course, they didn't have the relationship that the other siblings had who lived next door. But they are trying to make up for that. And, of course, we're getting moved into all of this conversation. But I do think it's a sensitive topic. I do hope that a person's faith would really be respected. There's no reason to disagree. We all would love to see this happen. There's the miracle, I think we all could agree with, well, it would be great. And we have to keep that conversation. I don't know if that answers exactly what you're looking for.
While we move the, go ahead. Sure. No, go ahead. You're there.
My name is Ian Shank. I come all the way from Northern Virginia for this wonderful conference, and I appreciate everything you said. This is real gray hair. I walked the halls of Osler 50 years ago when I graduated medical school here. And I was one of those ugly paternalistic physicians. Medical ethics didn't start until after I went into practice. But I was quick to relinquish that position to the autonomous patient. And I feel the biggest threat to ethical decision-making is what some ethicists have predicted for 30 years, which is that we're going to go from the age of paternalism to the age of autonomy to the age of bureaucratic parsimony. And decisions like this, are going to be more and more playing to those people who feel that we should have administrative policies to curtail waste of resources and similar economic decisions. And I think that we should recognize the patient's autonomy as precious. I'd rather be fighting this battle with the wonderful participation of an ethics committee than to have the lawyers, and I'm not against lawyers, but they ultimately will be making the laws that will decide these futility issues and be out of the hands physicians, but out of the hands of the family.
Yeah, so just in response to that, I think the model has also moved towards shared decision-making. So it really is a conversation with the patient about what the clinician feels, what the patient feels, and then trying to reach a mutually agreed upon plan of treatment. So hopefully the shared decision-making model acknowledges the autonomy, but also speaks to the beneficence and trying to figure out what's best. That again becomes our role in making sure the patient's voice is heard against these institutional or societal pressures that might be looking towards the economic incentives.
So I don't know if this has been said yet, so excuse me if it has. I think one of the things we've noticed is a trend of clinicians invoking medically ineffective treatment as a means for dealing with throughput pressures. And that's very worrisome to us, that this particular mechanism is being viewed as a resource management tool. And that it clearly is not the intent of either the law or our policy. And so it raises some important questions that need to be addressed, but not necessarily through this particular mechanism. And I think that making those distinctions are really important because there are risks in using this particular mechanism for that purpose, absent institutional, state, or national dialogue about how we're actually going to make that decision across the board. And I think we risk the individual interests at the bedside. That can be pretty problematic.
Some advanced directives are framed as a decision tree, and I think help patients understand what can happen if they, as a result of their decisions. But I have no idea to what extent these actually are being used, and when they're being used, how they are made, how their existence is being made known to people, to whatever institution the patient is brought.
So the federal law and state law requires that every patient who's admitted to a hospital be asked the question about whether or not they have an advance directive. First of all, how many people in here have one? I know we're getting ready for another session for next time. Oh, good. By the time we have our next Ethics for Lunch, whenever the one on advance directives, you will all have completed those. And then we'll have 100%. But to the person who has filled out an advance directive, clearly they're part of the medical record in our new electronic record. We've got tabs for it and so on. The important thing is that you bring it in. And as a member of the Ethics Committee and a lawyer here at the hospital, we do rely on advance directives. I mean, clearly the most important thing is designating who you want to make decisions for you in the event you become incapacitated. There is nothing more difficult for me and one of my colleagues than filing for a guardianship on somebody who has no one to make decisions. I mean, I would prefer that everybody designate somebody. And please make sure anybody who has an advance directive that your agent knows who you are and what you want. Because that happens to me a lot. I end up being an agent and all of a sudden I get a call from York, Pennsylvania saying, oh, by the way, you're a healthcare agent for so-and-so. I'm like, oh my God, I have no idea what they want. But that's the key piece. But clearly it is used as part of the decision-making for anything that the patient would want. If it's clear. Now, there's some people who have documents that say one thing and then the other thing and then the other thing and that kind of thing. It would be really helpful to sit down with your family when you have these documents, sit down with your care provider and go through what is it that you really want. And at the end of the day, if none of that works out, give your agent the power to make decisions that they would make, that you would have made given all the information.
I wanted to sort of get your perspective on how this conversation changes when you're talking about neonates and particularly at the border of viability when there's no
personally being coded nonstop on pressors and on a ventilator. And there is thought that it may be unethical in that perspective to burden a family with needing to put pen to paper and be the ones to make a decision to say, do not resuscitate when there is medical futility. So how does this conversation change when you're talking about babies who are at that border of viability or unlikely to survive?
So I think one of the important ways it changes is that we look to parents to be decision makers for their babies. And what you're describing are conditions of uncertainty. So generally, when we're in that place of uncertainty, we defer to families to help us understand what would be the best thing to do for their child. And I think there are different views about how parents want to make choices. Some parents do want to defer that decision to someone else, and for some of them it is a great burden to think that their decisions directly impact the timing and circumstance of their baby's death. So, I think one element of this that we've struggled with is the lack of consensus among the medical team about when an intervention actually is medically ineffective. And I think that creates a real challenge in trying to decide when it would be appropriate, perhaps, to institute a unilateral DNR in those circumstances. So we try often to get the team, the medical team, to come to consensus, but that's often not possible. And so one of the consequences of that is we end up having inconsistent plans of care or different values that are guiding that threshold, which creates a lot of confusion for people who are trying to, often at the point of care, to know how to respond. It probably contributes to people's moral distress as well. So I think there's the evidence part of it, then there's the how we actually negotiate those conversations with families. There is a compelling argument for, as we might with adults, of notifying parents that this particular therapy is not effective, and that there are limits on what we actually will do from a medical point of view.
When your life is guaranteed to start with a code, I guess the question is, and there's, for example, no evidence that in this population epinephrine has any benefit, right? Why then should I offer a family a menu of choices in order to satisfy what seemingly is a legal requirement and not necessarily an ethical requirement?
So I'll let Meg talk about the legal requirement, but I think one thing we have to be very careful of is if we actually are offering therapies that we believe are not effective, we're actually creating a false choice. We're creating the illusion that there's actually a choice that would benefit their child. So I think we have to be real careful about getting into the mode of offering things that we really don't believe or there's no evidence for just because of legal risk. And I'm going to let Meg talk about the legal risk.
I think, essentially, a clinician should not be offering things that aren't going to be effective and so on. I mean, we have so many families that want us to do everything humanly possible. We don't do dialysis on patients if we don't feel it's going to be appropriate. We don't do surgeries on individuals if we don't feel there's going to be a benefit to it. And, whether it be a neonate or be, any other individual, we shouldn't be offering procedures or therapies that really have no benefit, and we know that from a scientific standpoint.
So then how is CPR different? Because based on the policy that you read, it seems like I need 2 signatures, I need to present options to the family, instead of just saying, CPR is not going to work for your baby, here, hold them.
Essentially, you only need to go this medical and effective route when the family doesn't agree with where the plan is. I mean, physicians numerous times have conversations saying, I don't think resuscitation is going to be appropriate. and the family either engages or doesn't. If they don't, and it becomes to the point of medical ineffective, then that's when we have to go through this process. There are discussions daily with people about whether or not, resuscitation can take place.
I think in large measure it can be handled by the primary team taking care of the patient. And one of the main points is to provide a recommendation. So the clinician saying, it's not a menu of options that you can choose from, but this is the recommendation. This is what we know about you, your loved one, what we think is going to work medically, and this is our recommendation. If it is, we think DNR is appropriate, these are the reasons, based on what we know about you, based on what we know about the medical condition. So it's providing the recommendation, and only in those instances where there's disagreement might we need to be called. Hopefully, a lot of this, we have great clinicians here at Hopkins, a lot of this can be handled with the day-to-day communication that we have with patients and families, and not get to the point of these disagreements. So, great conversation. I appreciate those that were able to respond. It sounds like we could have just sessions on audience input about some of these key topic areas. As we said, this is just the first of many, hopefully, for Ethics for Lunch. We thank you. I want to point out the other thing is we do have institutional policies about these things. It's often, people don't realize we've thought about medically ineffective. We thought about DNR. There are, if you go to the HBO Hopkins Policies Online website, you can just type in a keyword, get the policy, you know the format of how to approach a particular case if you're struggling with it. And then always know that the Ethics Committee is a resource for you. Thank you all. Have a good day.